Alright guys, let's quickly do fungal keratitis. Now the most common fungus which is causing fungal keratitis is Aspergillus fumigatus. This is your previous year question. The other subspecies may be Aspergillus niger, Aspergillus flavus, and other fungus are Rhizopus mucor, right? Okay, but the most common remains your Aspergillus flavus. The patient typically gives a history of organic matter injury, something organic getting into the eyes. Sometimes the patient is milking the cows and the cow wags the tail and the tail hits the eye, because tail is a good source of fungus, yes. And while working in the fields as a farmer, so during sowing of the seeds, some dirt, some organic matter goes into the eye, that can also lead to this. But nowadays in urban population, due to excessive use of steroids, because steroids decreases the local immunity, that can also predispose the patient to fungal keratitis. Okay, steroids or antibiotics. Now you can see that this is the fungal corneal ulcer. Now I am going to tell you the typical features. One, the fungus is very dry looking. It is dry looking, and you can appreciate that the margins are fluffy or non-defined margins. What is this? This is your satellite lesion. So there is a main lesion, and surrounding this there is another lesion. Like moon is the satellite of earth. Earth is in the center and moon is rotating around the earth, yes. So like that. Now you can appreciate, what is this? Can you appreciate this? So this is your hypopyon. Hypopyon is pus in the anterior chamber. But mind you, fungus is the only organism that has the ability to penetrate intact cornea. No, I am not saying intact corneal epithelium. I am saying intact cornea. What are the bacteria that have the ability to penetrate intact corneal epithelium? It is Listeria, Haemophilus, Corynebacterium diphtheria, then there is Shigella, Neisseria gonorrhoeae, Neisseria meningitis. But they can penetrate only intact corneal epithelium, means one layer. But fungus can penetrate the intact cornea, all the layers: anterior epithelium, Bowman's, corneal stoma, Descemet's, Dua's layer, endothelium, yes. And hypopyon is fixed, and it is sterile or non-sterile? It will be non-sterile, yes. Okay, but the bacterial hypopyon is gravity dependent and it is sterile. So when the patient will lie down, the hypopyon will spread, and when the patient will do like this, so gravity dependent position, the hypopyon will come here in cases of bacterial keratitis. Okay, you can also see that there is congestion of conjunctiva, yes. And there is one important feature, that there is presence of Wesley's immune ring. Mind you, Wesley's immune ring can also be seen in viral keratitis, herpes simplex virus keratitis or herpes zoster ophthalmicus. So what is Wesley's immune ring? It is at the junction of normal cornea. So this is the normal cornea, this is the keratitis, है ना? So at this junction there is antigen antibody reaction, antibody of the patient, antigen of the fungus. So there is a formation of a line, or you can say the lesion is demarcated. So that is why you call it as ring. So this is your Wesley's immune ring. It is at the junction of normal and infected cornea, and it is due to antigen, which is your fungal antigen, and it is due to antibody, which is the host antibody. Yes, it is already here. And hypopyon, I have already told you. Okay, but the important feature that you should also be knowing is that here signs are more than symptoms. Yes. Now the patient will come to you and the patient will be relatively calm and composed, but when you will examine the patient's eye, you will feel that the patient must be in so much of pain, but the patient will be relatively calm. That means signs is what doctor sees, symptoms is what patient comes with. So signs will be more than symptoms. I am going to show you a patient, so you can see that the patient is relatively calm, relatively composed.
कितने समय पहले?
40 दिन पहले.
टिपिकल हिस्ट्री.
क्या काम कर रहे थे तब आप?
थोड़ा
मिट्टी वाला ही काम करन दे तूड़ी ताड़ी दे।
अच्छा, तो उसके बाद क्या हुआ? आंख चिट्टी पड़ गई?
नहीं जी, दर्द होनी शुरू हुई।
अच्छा, ऑलराइट।
उस तो बाद फिर मैं इलाज करवांदा रहा उत्थों जिथों बनवाई सी।
अच्छा,
ते वो इलाज जेड़ा भी वो नहीं हो सकिया।
ठीक है।
ते सानू इत्थे आउणा पै गया।
तो ये देखिए, you can see the eye, so it looks very white and it appears the patient must be in so much of pain, but right now the patient is comfortable and the patient is saying मैंने आंख बनवाई थी. बनवाने का मतलब cataract surgery. In vernacular language, आंख बनवाना is cataract surgery. Okay, now having done this, so what will be the treatment? So this is also your PYQ. If I am talking of filamentous fungi, the drug of choice is natamycin. If I am talking of non-filamentous fungi, it is nystatin, but there is new generation antifungals which are available, that is voriconazole. Yes, but if the disease is not controlled, you can even go for intracameral antifungal or intrastromal antifungal. Intracameral, intrastromal. Intracameral means you will give the fungal antifungal inside the anterior chamber. You inject it inside the anterior chamber. Intrastromal means in the stroma of cornea. Yes, stroma of cornea. And you can use which drug? You dilute the drug and can use amphotericin B. Amphotericin B can be given. There is another way of treating the fungus with fortified antifungals. What are fortified antifungals? So आप सबने नमक खाया है? नमक तो खाया ही है ना? टाटा नमक. So you know Tata Namak is fortified with iodine. So what does that mean? That means that iodine has been added inside the salt. So how do you prepare fortified antifungal? So we generally go for amphotericin B. Yes. So amphotericin B 50 milligram is available. I'm just giving you an example. So 50 milligram of amphotericin B is available. You will add 10 ml sterile water. Now the concentration that you have is 5 milligram per 1 ml. Yes. Now you further take 3 ml of this 5 milligram per 1 ml of this solution. So you have got 15 milligram of the antifungal. Yes, 3 ml. And you further diluted with 15 milligram total hogi. That means you have taken 3 ml. You further diluted to 7 ml. So now you are left with 1.5 milligram per ml. That will give you 0.15% of the concentration of amphotericin B. And you have to actually take this, put it inside the refrigerator at 4 degrees Celsius, and you have to use it in 7 days. That is the shelf life of this. And you have to ask the patient to keep putting this fortified amphotericin B every 1 to 2 hourly. Yes. And it has shown some beautiful results. So there is fortified antifungal. Similarly, you can even prepare for non-healing bacterial keratitis. You can use fortified vancomycin. You can use fortified imipenem or fortified third generation cephalosporin. So I just gave you an example how fortified antibiotics, antifungals are prepared. All right. So this is it about your fungal keratitis. I'll be coming up with more such quick videos. Best wishes.